All right. Okay. And hi to everyone joining online. So I'm so happy to be here. So today I'm going to be talking a little bit about some of the work that we're doing in my research lab. And today's presentation is going to be on the intersection of health equity research and implementation science. And I really want to lean into the community engaged principles and approaches that we're using in that work, because I think that they are really specific to the community that we're working with, but hopefully there are some things that you can take away that you might be able to do for your research projects as well. And I've prepared a lot of content, but I'm going to try to go quickly because I want to leave plenty of time for us to really talk about your projects or Q&A related to how you might apply some of these things in your work. So with that, we're going to go ahead and move in here. First of all, I just want to acknowledge these different funders who have contributed to different portions of the intervention that I'm going to be talking about today. So I've received some internal funds from Duke University as well as UWM, but also from the NIH. And then as Dr. Becker noted, I participated in the IRI and the RISE Fellowship. And the work that I do is really collective. You cannot do community engaged work on your own. So I just really want to thank all of my different partners in Milwaukee and my team, because really they are doing this work, and without them, it just really would not happen. So so grateful for them. So let me give you a little bit of an overview in terms of what my plan is for today's session. I want to start by talking a little bit about my connection to the work and my journey through implementation-focused health equity research. I will give you a little bit of an overview in terms of the work that we do at the Equity Research Group at UWM. I want to give you some context for the community in which I work, which is Milwaukee, Wisconsin. And then I'm going to zero in on one community, which is Latinos and Hispanics residing in the south side of Milwaukee. And we'll talk about one social driver of health that we're trying to intervene on, which is a culture of stress. And I'll talk a little bit about some of the community engaged strategies that we're utilizing in that work. And I want to end by reflecting on some of the implementation challenges or reflections that we're having, and some of the remaining questions that we're hoping to address in the next few years as we're doing this work. So with that, I want to take a step back. I want to introduce myself. So as Dr. Becker noted, I'm a clinical psychologist by training, and I really started my career in the evidence-based practice world, particularly with behavioral activation for depression. We were doing a cultural adaptation of that treatment. And in that work, I really started getting very passionate about cultural competence training for providers as a way to reduce mental health inequities. And the more that I did that work, the more that I realized that I really needed to focus outside of the clinic if we really want to make a dent on health equity. So in my postdoc and beyond, I really started thinking more about public mental health and thinking about community situated interventions that are more in the prevention space as a way to meet the needs of the communities that I was really passionate about working with. I really also want to talk a little bit about my connection to the work, especially in this era where we're really sort of prioritizing health equity. I think early on, or many years ago, in starting to do this work, there wasn't such an acceptance or an acknowledgement of how our identities and our connection to the work is really, really valuable and gives us a vantage point from which we can really do this work. So I come from a very long line of immigrants. My grandparents were Hungarian immigrants to Venezuela in the 1950s, escaping the Civil War. And then my parents themselves migrated to the United States to pursue education, but they really wanted to be with their family. So they returned back to Venezuela. But as you might know, in the 90s, there was a political regime that took over, and my family decided that the best thing for our family was to go back to the United States. And so we did. In the years that have followed, a lot of our family has now had to become refugees in different parts of the world because the political situation has been really difficult. And in fact, some of my family has returned back to Hungary, which is really ironic. And so, when we came to the United States, we moved around a lot. And these are just some of the states where my family lived. And having that experience of moving around a lot and migrating and traveling to different places really got me up close and personal with what the concept of acculturative stress really means, and really sort of thinking about the structural forces that shape the day-to-day experiences of communities that are marginalized. But at the same time, I don't want to focus on a one-story narrative of immigrants as just hardship, because it's so easy to focus on that, and that's what we see in the media. But I got to tell you, when I'm working with these communities, they are so strong and so resilient, and I just so admire what they have to go through on a daily basis. And so that's a really big part of how we come into this work as well. And I have to note here that my story is not unique, right? And there isn't one story of immigration. Every story is going to be different. But I work with community members that maybe are experiencing different systems, or they're experiencing the systems of privilege and oppression in different ways than I have. So, I have been impacted by racism and xenophobia and classism and LGBTQ intolerance, but I too have benefited from so much privilege, right? So to name a few: citizenship privilege. I was born in the United States, cisgender privilege, education privilege, socioeconomic privilege now, um, my ability privilege, right? And colorism privilege, right? And so as I'm doing this work, I'm really thinking about how all of these systems and identities really interact to shape my experience. And I think that that's really helpful in this kind of work. So as I progressed through my career, I've been really plagued by some questions, and I don't presume to have any answers. I really have more questions than answers at this point. But I've really reflected on, why is it that some communities live in environments that are not conducive to health? And how is it that one's identities and backgrounds determine the kind of mental health challenges and outcomes that someone might experience? How is it that once you are born into an environment, your experiences with chronic stress and adversity are so entrenched that it's really hard to move out of that? Why is it so hard for some members of our society to navigate basic necessities like the healthcare system, the legal system, the education system? And how can we increase the reach of the interventions that we know work, that have lots of evidence behind them, into communities that have had a lot of access issues, right? And so these are some of the questions that we're really invested in at the Equity Research Group. We are at the University of Wisconsin-Milwaukee, and these are some of my undergraduate team members. But at the core of it, we are interested in developing, testing, and disseminating interventions and implementation strategies that are focused on ensuring equitable, high-quality mental health care for underinvested communities, as well as building inclusive and culturally conscious treatments for youth, adults, and families. And we try to really merge a lot of different approaches and frameworks. So we're really interested in implementation science. We're also really interested in health equity. We draw from a range of methods. So we use quantitative, qualitative, and mixed methods. And we also really rely on human-centered design principles so that we are building things that are very useful and relevant for the communities that we're trying to reach. We have projects with different communities of interest, including individuals who may be experiencing poverty, food insecurity, and homelessness, LGBTQIA+ individuals, Indigenous peoples, and immigrants and refugees. Today, I'm going to focus on immigrants and refugees in particular, and in particular, those coming from Latin America. So I want to take a step back and give you a little bit of context for the city that I'm living in, the community that I have begun to call home again. So I live in Milwaukee, and Milwaukee is the third most segregated metropolitan area in the United States. And the hypersegregation in Milwaukee is due to a legacy of housing and lending discrimination, as well as underinvestment in communities of color, public school system zoning, and urban planning practices that have promoted the separation of racial and ethnic groups. This is a very similar story to what you also experience here in Chicago and many other cities in the country. So this systematic marginalization of low-income communities of color is not a thing of the past, right? It is alive and well. And we still see present day contributors to this, for example, gentrification that is happening in certain neighborhoods. So on the left here, you see a map of how Milwaukee was zoned actually by lenders. And I believe that was in the 1940s. And on the right-hand side here, you see a map of Milwaukee now and the concentration of communities that live in these parts of the city. And so as you can imagine, the more affluent areas are near the lake and out in the suburbs. And the Latino Hispanic community lives in the south side of Milwaukee, which is predominantly low income. And the Black and African American community lives in the north side of the city, which is also very low income. And so why does this matter? I feel like I don't really have to emphasize this point because I know the audience that I'm talking to, right? But just to make the obvious point here, these kind of policies have shaped the degree to which there have been financial, sociopolitical, and environmental investments in these different neighborhoods, right? And the lack of investment has given rise to a range of social drivers of health, particularly in the south side of Milwaukee and the north side of Milwaukee. So what are we talking about? We're talking about housing instability, unsafe housing, the level of violence that might exist in a neighborhood, the amount of property taxes that support the local schools, access to green space and walkability, availability of affordable and nutritious food versus having food deserts, environmental pollutant exposure, and there's so many more. I'm just naming a few here. I want to do a deep dive into the south side of Milwaukee again, which is the community where I'm primarily working. And I just want to put a few stats here to give you some context for what the communities that I'm working with are dealing with on a daily basis. So what I've done here is I've selected high priority census tracts that have at least 75% concentration of Latinos or Hispanics living in those communities. So you can see that here on the second column. And then as we move to the center of the table here, we see that we have poverty rates ranging from 25% all the way up to 40% in those census tracts. The median income is ranging from 27,000 all the way up to 42,000. That's family household income. And then the social vulnerability index is a composite of 16 indicators where 0 is very low social vulnerability and 1 is the highest that you can get. And so what you can see here is that people in these neighborhoods have very high concentrated social vulnerability, as well as lots of people who are uninsured and disabled. So we know that these conditions are bad for health, right? Because they determine your health status as well as your access to healthcare. And all of these things are really interconnected. So the chronic exposure to these stressors, right, can be everlasting and they can feel really intractable. And what I really like to highlight, especially when I'm working with community members, is that a lot of these things are systemic and they're structural. It's not a moral failing, right? It's not a choice. Oftentimes we have people who have lived in these neighborhoods for generations and generations, despite their best efforts to move up the social ladder. That has not been able to happen for many of them. And one stressor in particular that we're really interested in intervening on is that of a culture of stress. So what is a culture of stress? Okay, I'm going to start by telling you a story. This is not a story of all immigrants, but it's a very common story. So what I've depicted here is the before, during, and after. And I see that my after didn't quite make it on the slide here. But before migration, a very common narrative that we hear in the work that we're doing is that even though there is considerable stress that might be prompting someone to move out of their country, they're also having a lot of resilience factors that are making them quite healthy. They're having higher consumption of fresh fruits and vegetables. They have larger kinship networks, closer familial bonds, more physical activity, shorter work days, reliance on religion as a source of strength. They have lots of cultural strengths, right? Hard work ethic, optimism, grit, all these sorts of things. And we know that migration journeys can be really traumatic, and they can range from being very stressful all the way up to being very traumatic. There's lots of pathways to migration. One thing that we have found in our research is that even though that journey is really stressful, there can also be a lot of resilience along the way. And one factor in particular is optimism in the American dream. And that can really carry you a long way for the first few years when you're really going through that process, right? Because there is the hope that even if you put your time in, and even if you are going to be going through these circumstances, eventually you're going to be able to move to achieve the American dream and provide a better life for yourself and for your children, okay? But what we see is that, again, coming back to what I was talking about, these systems, it's really, really hard for communities to move up the social ladder, right? And it's something that a lot of members of the immigrant community maybe don't realize what the context is like in the United States when they are outside of that context. A lot of community members talk about not realizing how hard it is even to meet your basic necessities. And so when Latino immigrants in particular arrive in the United States, they actually have a relative health advantage. This is known as the immigrant paradox. And the reason it's a paradox is because, again, there is sort of this perspective of, wow, there's so much stress. If people had to leave their homes, they must be in really poor health. But in fact, it's all the resilience factors that I talked about, and also probably some selective migration that contributes to better health in that population. But the other thing that happens is that the longer they're residing in the United States, the worse their health becomes. And not only within that generation that migrated, but also in the children of immigrants and in subsequent generations, okay? So why might this be the case? There has been a lot of scientific inquiry into all the different factors that might be contributing. And two in particular that we really like to focus on is that of acculturation and acculturation stress. Now, this is not an exhaustive list, but we think that acculturation contributes to this in that through that process of adapting to life in the United States, community tends to pick up lifestyle behaviors that are not conducive to health. So things like being more sedentary, eating more processed foods, relying on the car more, being more isolated, those sorts of things. And we think that acculturative stress is a really key social driver of health decline. And so these are the challenges that people experience before, during, and after migration. So let's talk a little bit more about what they are. So these are the sorts of things like having to learn a new language, experiencing discrimination, not having the same rights to housing or healthcare as people who maybe were born here. And these kinds of drivers are rooted in systemic oppression. And again, lots and lots of research has shown that this is a primary driver of health decline in Latino immigrants. These are different facets of acculturative stress. We use a measure that's called the HSI, which is the Hispanic Stress Inventory 2. And that has 90 items, and it falls along 10 different subscales. And so they have to do with the kind of stressors that show up in families and with parenting, especially in the context of having children or other family members who migrate at a faster rate than parents, or sorry, acculturate at a faster rate than parents, and the kind of the conflicts that can come from that. It also has to do with discrimination. It has to do with not having healthcare access, with occupational stress, working in high risk, low rewards kinds of occupations, language related stress, all sorts of things, right? And we can also take a socio-ecological systems perspective to these acculturative stressors. So, you know, we could have the immigrant in the center, and we can think about their pre-migration context, and we can think about their own vulnerability to stress. And if we zoom out and think about the family context, we can think about the kinds of relationship conflicts and stressors that might be happening in the home. And then we can zoom out and think about what's happening in the neighborhood context. And so things like not having adequate access to healthcare, isolation or living in segregated neighborhoods, lack of high quality education, poverty, violence, all the kind of things that give rise to stress. And then we can think about larger societal issues like the sociopolitical context and hostility towards immigrants, right? But at the same time, we can also think about resilience factors in that same way. And so we can think about an immigrant's ability to self-manage that stress, their self-efficacy, their sense of optimism. We can think about strong family ties that might be happening in the family and their relationships. At the neighborhood and community level, we can think about the kinds of resources that might be available to them, their access to those resources, also their connection to other members in the community. And in the larger societal level, we can think about safety net programs and all the ways that there are systems to integrate migrants and refugees, right? We did some qualitative work to try to understand this phenomenon of acculturative stress a little bit more. And one of the ways that we like to think about it is that there are these sort of hidden roots, and then that gives rise to these visible manifestations, which are the health outcomes that we often talk about. And so this is the same information, but just sort of shown in a different way, right? Where we can have at the high level, these sort of social stressors that are happening, right? Inhumane migration, detention, global and national event, anti-immigration laws, that kind of stuff. And that can trickle all the way down to mental health symptoms, chronic health conditions, physiological reactivity to stress, lower quality of life, and there are other indicators. And I want to pull out a couple of quotes that have come up in some of this work. So one person says, well, the health of going to the doctors, I've been here 18 years and I still don't understand how it works. Well, I go when it's really necessary to the Lincoln Clinic. Once I was almost dying because I didn't go to the doctor. The doctor told me that if it took me another day that they wouldn't be able to do anything for me. And well, yes, I don't know why that system is so complicated for me, right? Another person says, I feel lonely in this situation. Even if I tell someone about it, they will not understand me. They will not feel, they will not understand what I say or what I feel, not exactly what I feel, my pain, to see that it really hurts, and what this all implies. I don't know how to explain it. I think that losing someone like that so close to your heart and so far away because he was there and I was here, I think that this is what hurts the most to all the people that cannot go and return, right? And in particular, this participant was talking about not being able to be with their dying parent in the final days because they couldn't leave. We also know that one's experience of acculturative stress is really shaped by different identities. And so this is shaped by your country of origin and even the corresponding migration laws to that country, your race, your SES, your legal status, your gender and sexual orientation, your educational attainment, your language proficiency, and so much more. We did some work to try to understand how common these acculturative stressors are in the general population. And we did a study with 391 immigrants in North Carolina, young adults. And we found that 65% of the sample had an overall elevated rate of acculturative stress. And when we looked at which were the acculturative stressors that were most common, they had to do with the pre-migration and migration circumstances, as well as family stress. And again, you can sort of imagine why that might be the case, especially if you have children who are at school and picking up culture and language, and then coming home and you're having lots of cultural conflict, right? We also did some work to try to understand whether there were some acculturative stressors that tended to cluster with one another. And what we found were 3 distinct clusters. So in this sample, we found that there was a group in cluster 1 that had high acculturative stress, but they didn't have parental and marital stress. Cluster 2 were people who were high in parental and marital stress. And cluster 3 tended to be people who were low in acculturative stress. So I want to sort of zero in and take a closer look at these groups. So what we found is that cluster 1, again, that is the people who are high in acculturative stress but have no parental or marital stress, tended to be people who had unauthorized or undocumented status. And Then cluster three tended to be, so again, going back, cluster three tended to be people who were low in a culture of stress. Those were people who spoke more English. They were people who completed on average at least a high school education. They had more household income. They had access to health insurance. They had more emotional support. They had more instrumental support, right? And so when you are in the margins of society, that is bad for your health, right? And how do we think about this? Well, social drivers of health, in this case, a culture of stress, gives rise to prolonged psychological and physiological stress responses, right? And there can be buffering resilience factors as well as unhealthy coping that comes with that. But then that can give rise to health inequities. And when we're talking about health inequities, often we're talking about higher chronicity of symptoms, higher recurrence of symptoms, higher burden of disease, lower quality of life, more disability, more premature mortality. And at that point, we can also have mitigating and exacerbating factors. But then we can also have the emergence of the healthcare inequities, which are lower engagement in health systems, lower health screening, lower monitoring, higher delays to care, lower receipt of formal mental health treatment and follow-up, right? And so what we know is that the current landscape is just insufficient to meet the demands in the community. And this is so evident in the time of COVID, right? And our already overburdened system just has gone to full collapse in lots of neighborhoods. Why? Because of the surge in COVID cases, because of resource shortages, staff burnout, supply chain disruptions, delayed and non-COVID care, a lot of the information overload that we were receiving, and financial strain on systems and people. Okay, so in order to address the problems of a culture of stress and low access to care, my team developed the Cultivating Resilience intervention. So this is the traditional approach to intervention development, which you're probably very familiar with. And this takes a very long time, as we all know, right? Where you start with identifying a significant clinical question, and then you are defining and refining, and then you do proof of concept, then you do pilot, you do efficacy trials, then you get to effectiveness. And then we haven't even talked about disseminating it and implementing it, right? And so recognizing that the need is now and that we need to address, we've been really trying to think about how do we speed up this whole process, but do it in a way that's very rigorous. So we've been really focused on designing with implementation in mind alongside our community partners. We try to pull from, again, human-centered design, community engaged methods, implementation science frameworks and methods, as well as drawing on our CBT toolkits to really think about the kinds of components that already have a lot of evidence base behind them. So I'm going to show you the double diamond model of human-centered design, which is what we utilized as we were building this intervention. So you start with a design challenge. And here we have divergent thinking. We are really trying to do our research to get our hands around what the problem is. We did an evidence map. We did interviews. We distributed questionnaires. We had lots of meetings with community partners. And then we get into convergent thinking. And so we sort of bring forth all the insights. And that really allowed us to reframe the problem. And we identified themes, we interpreted those findings, we synthesized those findings, we refined the problem, and we framed opportunities. Then we had divergent thinking again, and we got into the ideation phase. We did brainstorming, design, sketching, prototyping. We got feedback, and now we're pilot testing the intervention. And what you can see here is that we move from solving the right problem to solving the problem right. And then we finally end in the convergent side and the implementation. So we're probably somewhere here in between ideating and implementing because we're doing our first pilot of the intervention. And here at this phase, we are refining, we're adapting, we're disseminating, and ultimately are hoping to get to an outcome. This is a conceptual model of how we think that this intervention will work. Again, we're collecting data now, so we don't know. But the first component is psychoeducation. And we think that that targets increased stress appraisal as well as increased knowledge acquisition related to a culture of stress. The second component is mindfulness training, and we do deep breathing and we do gratitude practice. And we think that that will allow people to have increased somatic awareness to recognize those stress cues that are happening in their body. The third component is values assessment. And we think that that targets greater values clarity as well as increased values aligned activation. So getting people to do more things that are important and meaningful for them, right? The fourth component is structured problem solving, and we hope that that will help people have greater self-efficacy and allow them to solve the kinds of routine problems that they are encountering in their day-to-day life. Fifth component is interpersonal skills training, and we hope that this will yield enhanced social support and decrease social conflict. And component 6 has to do with resource connection, and we hope that this will target reduced social needs. And so what we do is we ask people at the baseline assessment what social needs they have, and we give them resources. And then we keep following up with them through the intervention to figure out whether they're having any challenges connecting with those community resources. They attend 8 weekly sessions, and we are assigning homework in between sessions, although that is not going very well. People are having very chaotic lives, and the homework is not always happening. But we hope that that will ultimately reduce a culture of stress and therefore reduce cardiovascular risk factors, improve sleep quality, and mental health symptoms. This is an overview of the session content, so I won't go into all the detail, but what I want to highlight is that in the first session, we're really providing an orientation to what we're going to be doing in the workshop. And it's a group intervention, so we're doing agreements and sort of getting people connected to what it means to do this kind of a group intervention. We then move into talking about stress. So we define a culture of stress, we talk about the impacts of a culture of stress, and we begin to think about how we might resolve those culture stressors. And then the remainder part of the sessions are really focused on resilience. So again, bringing that socio-ecological systems perspective, we talk a lot about internal strength and we talk about values, and then we move into family resilience. Then we talk about connections in the community, and then we talk about broader social connections. I just want to highlight a few of our sample handouts here. This is a metaphor that we use for an individual and the kinds of internal strengths and familial bonds and other resilience networks that root them. So these are the resilience factors at the bottom. And we talk about how there are necessary nutrients that trees need to grow. They need sunshine, they need rain, right? But there can also be stress, which might be like the storms that set in. And sometimes there might be tornadoes or natural disasters, which are symbolizing trauma, right? And we talk a lot about how migration is like being uprooted from one environment to another environment, and that because of all of these stressors, our tree can get sick over time. But that what we're really trying to do is get replanted in a new environment and hope that our tree can be strong and beautiful and resilient. We talk about the different types of acculturative stressors, and people can reflect on which of these might be relevant for them. And then we sort of talk in the group about the different kinds that people might be experiencing, the impact of these things in your mind, your body, your soul, your social relationships, that kind of stuff. We talk about strategies that can help manage stress. So helping people see that caring for themselves is going to be helpful, thinking about cultural ways that they can care for themselves, limiting their consumption of substances, those sorts of things. And right now we are doing a pilot RCT of this intervention. And so what we have done is we have randomized sites, 4 community sites, and we have some that are in the active condition and some in the waitlist condition. And 2 are in the active condition, which are at a church and at a school. And the other 2 are a community health center. And then we decided to do a virtual group. And the reason we have all these different sites is because we were really trying to figure out where should this intervention reside, right? And what kind of things are needed so that they can be usable in a range of different settings. And so here are some pictures of the different sites. And so it felt really important for us to do this in community settings, right? Why? Because we want to evaluate this intervention in real world settings from the get-go. This is really what we're talking about in terms of designing with implementation in mind. We also go to the community instead of waiting for the community to come to us. This helps us reduce barriers to engagement for community members, and it helps us capitalize on the trust that's already built within those trusted community sites. And it also allows us to get a better sense of the contextual factors that might really influence implementation when we really decide to roll this out on a larger scale. So how do you reach hard to reach populations? You have to go to them, period, right? Like we have found time and time again, not only in my work, but in many scholars have talked about this, that we cannot expect the community to come to us. And so we have to develop partnerships with organizations that are trusted, and we have to determine the extent to which there is missions alignment, right? We have to be agendaless. We have to be willing to go with the priorities of the community. And that does not always align with our grant deadlines, right? And the RFAs. It just doesn't. You have to show your face. You have to go to their events outside of your recruitment activities. You have to volunteer at their events. You have to build those relationships. So our team has gone to community festivals, food pantry distribution events. We've gone to a lot of church services, health fair, community conferences, right? So that we can be known in the community. At the same time, it's been really important for us to offer our assistants our time and our resources. And so when we leave community meetings, we always ask them, is there anything that you need, right? Are there any resources or any connections or just any expertise that we can lend you that would help further the mission of your organization? We also share with them opportunities that we are learning about for grants. And we also offer any other kinds of help that they might need in putting together grants and making those connections for them. We've also developed an ongoing community advisory board. And so we meet with our board on a quarterly basis, regardless of the projects that we have going on, because we think it's really important to be, again, showing our face, but to be hearing about what the priorities are for the community. I'm going to just speed through this stuff because I'm sort of running out of time here. So we do a lot of in-person recruitment, but also our study coordinator is from the community. And so she's very knowledgeable about the kinds of things that are needed and how to troubleshoot that ahead of time. We collect names at community events, but then our coordinator spends a lot of time calling each individual person, answering all of their questions and getting them really understanding what these research studies are all about. For our virtual group, we have a lot of people who are enthusiastic, but some don't even have an email address. So we spend time getting them connected to email and to Zoom. All participants get reminders for any touch points with our team through text, through phone calls. These are some pictures of us being out in the community. And then the people in the active condition do a baseline assessment, they receive the intervention, they do a post-assessment, then they have a follow-up period, and we do another assessment with them after 2 months. And the waitlist condition does a first baseline assessment, then they're in a waitlist period. They do a second baseline assessment, they receive the intervention, and then they do a post-intervention. And while they're doing the intervention, they're also filling out weekly surveys related to the implementation process. And we are also taking observations and notes as we're implementing so that we can sort of be learning about this. All of our items are administered verbally because we have a lot of members of the community who haven't completed a lot of formal education. And we do visits in their homes. We do them at community sites. And sometimes we do them at our lab, although less so. So here are just some early reflections on this implementation process. we have to balance doing the work while also maintaining the safety of the team. We are working in communities or in neighborhoods that are very, very dangerous. And so we've had to really think about how to protect the team. We have shown up, and there's been there's been 3 times that I can think of where there's been gunshot violence in earshot. We also have to think about, again, where can this be implemented? We are learning that this can be implemented in lots of different places, but what we have to think about is what kind of implementation supports are needed for each of those sites. We've learned and know that trust can be very hard to earn, but very easy to break. And so once you build it, we have to keep the momentum going. And so we're really designing a lot of activities outside of studies to continue meeting the needs of the community. Regarding reach and sustainability, we have to really think about the box in terms of who can facilitate these interventions. So we are thinking about community health workers. We've even had questions from people who've participated in the intervention so that they can get trained up on delivering the intervention. At our church, we've had conversations around the priests getting trained on the intervention, which is really fun to think about. And now this is a really good problem to have, but we have way more people who want to enroll than we can actually enroll. So now we have to really think about, are there other ways that we can meet the mental health needs, again, outside of a study context? So to finish here, here are some questions that we're really hoping to address. So for whom and why does this intervention work? What are the key and adaptable components of the intervention? In which settings should the intervention reside? Can we sustain these interventions in those different settings? What kind of implementation supports may be needed to do so? Who can we train to deliver the intervention? Can we train those people to deliver the intervention to fidelity? And what are indicators of positive and negative drift from the protocol? And the last point is that this is a prevention intervention targeting stress. And yet, we are hearing a lot about depression, anxiety, insomnia, and trauma, and we are hearing people really wanting more content related to that. So we're having questions around, do we build out modules that address those things, or are those new interventions? So we're really having to think about all of those things. So with that, I just want to end with the Q&A. So thank you so much for your attention.
That was outstanding. Thank you so much to Dr. Nagy for such a riveting talk. I also was tweeting about you and getting some love on what was once, I guess, Xing about you now. But I'd like to open it up to the room for questions, and then we'll also field questions. I can see that there are 3 in the Q&A via Zoom as well. But let's start in the room. Any questions? All right, I'll bring you the mic. And if you could please just introduce yourself before you ask the question for those that can't see you.
Hello, I'm Benji. I'm a postdoc here in medical social sciences. I'm curious about the approaches to reducing stress that you think have most promise, especially for a culture of stress. Like I saw that there was some use of mindfulness practices and different approaches, but what do you think, like, should it be handled in ways of like other kinds of stress, or is a culture of stress special in some way?
So you're wondering whether these components can intervene on other types of stress primarily, or which of these components might be most helpful for reducing?
Yeah, like if you have intuition about which kind of component is the most useful for that kind of stress.
We are just we're rolling this out, so we haven't reviewed the data, it hasn't come back yet. But anecdotally, I can tell you that mindfulness has been a really big hit. People have really appreciated learning about how they can do informal mindfulness through their day, deep breathing, giving themselves space to feel what they're feeling. So that has been really helpful. People have also really enjoyed this idea about doing pleasurable activities, self-care activities, value-aligned activities. I think some of the harder strategies are like structured problem solving, especially when problems are so systemic and out of your control. So that has been a little bit harder. And yeah, we're just bumping up against that, right? That a lot of our community members are living in environments that are just inherently stressful, and we can't do anything to remove those things, right? So we're really finding a lot of movement in the strategies to have sort of like a different relationship with the difficulties that are coming up. But we'll see which components come out as like the most central. Thank you.
All right, I can see Dr. Betis have her hand up. I'm going to get my steps in today. Hold on.
You. Dr. Nagy, thank you so much for that incredible presentation. You modeled your values, your positionality, and the way that you approach your participatory work beautifully. I was curious if you could reflect on what you would like institutional, organizational leaders to know about how to support the development of more researchers like you who are able to do work like this in the community.
Thank you, Dr. Betis. I will say that one of the things that has been really helpful in the last year or so of doing this is that there's a lot of activities that are not funded through grants, right? There's a lot of taking your partners out for lunch or coffee. There's a lot of FaceTime, hosting things that just take money and take time. And so a couple of things. Financial investment from the institution for those activities that are not clearly within grants, or even all the things that are necessary to even think about putting in a grant, is really, really crucial. Having support for doing this kind of work and even like hosting things like this, I think are very, very helpful. Getting training for the department in terms of how to do community engaged work, health equity work, implementation science, so you have like younger folks really learning how to do this from the get-go, I think is really helpful. Yeah, like really trying to focus on the institutional ties to the community, I think can be really helpful. Thank you.
All right, I'm going to take a question from Zoom. We had a question from, I'm not sure if it was Tabitha or Tabitha Rivera. I wonder if you've considered the benefits of providing your session participants with toolkits instead of homework, and then invite them to discuss in subsequent meetings how effective the toolkits have been in their day-to-day lives.
I love that reframing. Yeah, I love that. Yeah, homework seems really oppressive, right? Like you have to do the homework. That I love that change of language, and I think that that's definitely something that we can incorporate. I'm trying to think about how to translate that into Spanish, so I'll have to give it some thought.
Great. And you got some praise from Ashley Knapp saying not a question, but yes on testing the intervention in community settings at the get-go. Gabby, you are doing rigorous and impactful work. It's inspiring. Thank you for sharing your fabulous work. And if you know Ashley, there's a ton of exclamation points.
Thank you, Ashley.
Okay, any other questions? We do have some more via Zoom. I can go to the next one. Rebecca Johnson saying, really great presentation. Thank you. What is it that people like most and are signing up for? For example, is it the content, takeaway techniques people can reuse, training together, creating trauma-informed communities, etc.?
Yeah, thank you for the question. I suspect that a lot of the reason why we're having so much interest in this is because there are huge access issues in Milwaukee. We have several clinics in the south side of Milwaukee, but to get in is a several months wait list. I think I heard 4 months to get in for an initial appointment. But once you're in there, you have to wait a few more months to get a second appointment. It is really, really hard to have mental health interventions and access. Meanwhile, the community is really, really experiencing super high stress and really high mental health problems. So I think part of what they're resonating with is that when we start talking about stress and well-being in ways that are, you know, non-blaming and really consistent with their lived experiences, a lot of times people are like, yeah, I have that, you know, and they're so excited to connect and find something that may be helpful to them. I will say too, I think the in-person contact is really, really helpful, and just getting to hear their story and telling them how we think that the intervention could be helpful for them is really resonating. But we don't have the data yet to know what aspects of these are really helpful.
Great. And I see one over there. So we have Dr. Sarah Helseth, who's faculty at the Center for Dissemination and Implementation Science. And I'm going to pass her the mic in a moment.
Thank you so much for that wonderful talk. I really enjoyed it. I think one of the things that you said about trust building and breaking really resonated with me. And I'd love to hear if you had examples from your own work or from others who you have worked with, or even from community members, examples of instances where events occurred in the context of a research study that broke the trust with the community members
Mm.
and that maybe caused kind of that fracture and how you can repair those things. Because they sometimes in the context of research, it doesn't align with the community members' interests and
Yeah,
pathways that they want. So
yeah, yeah. Well, I will say that, we've sort of learned by trial and error what kind of things work. When I got back to Milwaukee, I was so excited to test out this intervention that I had been developing in a different context in North Carolina. And I came back and I was ready to go. And I had to like really sort of remind myself of the importance of spending a lot of time listening to priorities from the get-go, right? Rather than jumping into, oh, I have an idea for a project that I think might be really helpful for you. So I recall sort of coming away from several meetings thinking like, ooh, I don't think that that conversation really went well. I hope that I'm not sort of perpetuating the same sort of patterns that academics get accused of, which is sort of like coming in with an agenda, coming in for a project, and then getting your data and leaving when it's done. So it's been a lot of having to volunteer at events and keep going. And over time, we've had some of those the people who we had those conversations with actually come back out and reach to us and ask us about what we're up to and how we can partner. So yeah, I can think of other examples too. I don't know, are we good on time? Or yeah, I can think of one other thing, which is when you're working with different community agencies, you might sort of buy out the time of people who work at those agencies, right? And then you might apply for different grants. I have seen teams kind of like poach people away, and then that really break the trust of those community partnerships, right? So that's not it's not good practice. There's a lot of politics too when you're working with lots of community agencies. So sometimes when they learn that you're working with a different organization that is maybe like a rival organization, that can be really tricky to navigate. We had in one of our sites, they were really interested in the intervention, and they sort of said offhand, like, yeah, we want to do this, but you're not going to do this with anybody else. And I thought it was a joke. So I walked away. I was like, oh yeah, okay. And then we had another meeting. I said, yep, so we're rolling this out in multiple sites. And they looked at me, they're like, didn't I tell you that we just wanted this to be here? And I had to really take a step back and say, I hear you. And we had those relationships before you and I even met. So and these are the kinds of questions that we're asking. And this is why it's really important that we have this intervention in multiple places. And having that conversation authentically really allowed that person to say, okay, I get it. I understand. All right. And then we were able to move through that.
All right, we have 4 minutes and 2 questions in the chat. We'll do our best to get to them. One from Adrian Ortega saying, thank you so much for an amazing presentation. I'm a postdoctoral fellow and psychologist at the Center for Behavior Intervention Technologies. We have a lot of CBITS folks in the room, yay. I've done some research on the role of built environments impacting physical health in adolescents from marginalized backgrounds. I'm wondering what your thoughts are on how we as psychologists can address structural/built environments that can't typically be addressed in one-on-one interventions.
Ooh, gosh, that is such a complex
Yeah.
question. I'm so sorry. I don't know that I have the answers to that problem. Yeah, what do we try to do? I mean, I think that we try to think about, are there things that are within the control of the individual, right? So if we're trying to do like a lifestyle intervention, I might really think about what's already within their reach that may be helpful. But in terms of the larger things like neighborhood violence and food deserts and things like that, that is, I commend you for doing that work. I'm gonna have to simmer on that question a little bit.
Okay, and I'll have one final from Connie Chow. Absolutely love this work and your presentation, Dr. Nagy. I'm a PhD student at Northwestern working in/with domestic violence nonprofit agencies and was wondering how you onboard and offboard your undergraduate or other students while doing this longer term work with the communities.
Thank you. We invite our undergraduate students to come volunteer with us, and we invite them to our community advisory board meetings, and we get them to visit the different events that we have. We also have a tiered, like what we call like a nested mentorship model, where we have our postdocs and grad students do a lot of close mentorship of our undergrads. And we also have large group meetings. And so we're really trying to sort of explain things as we're doing it and highlight for them why it's important and why we've made the choices that we've made. We also have an implementation science for equity journal club, and we invite them to that as well. So that's really helping them very early on in their training to be grappling with these questions of equity and implementation science.
All right, wonderful. I think we're going to wrap. We will email any attendees who didn't have their questions read out loud on Zoom and have Dr. Nagy send a response to your question to address any burning issues. Dr. Nagy, do you have any version of these slides that could be shared with attendees?
Yeah, sure.
Okay, wonderful. So if you were taking furious notes, I saw some people in the room taking lots of photos. We can make a version of the slides available, and just wanted to thank everyone for attending. And if you're in the room, there's a class here in 15 minutes, but you have a little bit of time if you want to mingle and chat with Dr. Nagy. Thank you all so much for joining.